Welcome everyone, and thank you for joining today's session on functional gastrointestinal disorders in infancy with a focus on nutrition first management. This presentation is intended for healthcare professionals only and is not for distribution to the general public. Today we'll explore infant FGIDs, which stands for functional gastrointestinal disorders in infancy, their prevalence, diagnosis, impacts on families, and the role of nutritional management in improving outcomes. By the end of today's session, you'll be able to first distinguish between the major FGIDs, such as constipation, infantile colic, and regurgitation, understanding their prevalence, symptoms, diagnostic criteria, and management approaches. Second, summarise the importance of parental reassurance, as well as when nutritional interventions should be considered. Third, recognise FGID symptoms and know when to recommend nutrition-first strategies and when escalation back to a GP is required. Finally, you'll be able to recall current guidelines that support management of these conditions in infancy. Before diving deeper, let's start with the ABCs of the FGIDs. A, what are they and how prevalent are they? B, how they diagnosed, and C, what is their impact on infants and their families? And as always, I'd like to reinforce that breast milk is the optimal source of nutrition for infants, and supporting breastfeeding should remain our first priority. Functional gastrointestinal disorders are extremely common in infancy. In fact, more than 50% of infants in the first year of life will experience at least one FGID. Although these disorders are usually temporary and self-limiting, they can be distressing for families and often lead to repeated healthcare visits or unnecessary interventions. This highlights the importance of clear guidance and reassurance for parents. One of the challenges in managing infant FGIDs is that multiple conditions often occur together. A key prospective study found that around 78% of infants were diagnosed with more than one FGID at the same time. This overlap can amplify distress for both infants and parents, making effective communication and management strategies even more essential. Now let's clarify some terminology because misinterpretation can lead to inappropriate treatment. Regurgitation refers to passive movement of stomach contents out of the mouth, commonly called spitting up. It is a normal physiological process, especially in infants under 6 months of age. Reflux or gastroesophageal reflux is also normal. It involves movement of stomach contents into the esophagus with or without visible spit up. Gastroesophageal reflux disease, however, is when reflux causes troublesome symptoms, such as poor weight gain, feeding refusal, or signs of esophagitis, and this is when medical intervention may be necessary. Importantly, most infants with visible reflux symptoms simply have benign regurgitation that resolves naturally within the first year. Next, let's look at colic and constipation. Colic is defined as recurrent, prolonged crying in an otherwise healthy infant under 5 months of age. Parents often describe clenched fists, legs drawn to the chest, and periods of inconsolability. Symptoms usually peak around 4 to 6 weeks of age and improve by 12 weeks. Constipation, on the other hand, involves infrequent or difficult stools, such as fewer than 2 bowel motions per week, excessive stool retention, or hard, painful stools. It's important to note that constipation is rare in breastfed infants, so if it occurs, feeding technique or formula preparation errors should be checked. Regurgitation and reflux in young infants largely occur because of the immaturity of the gastrointestinal system. The angle of His, which helps prevent reflux in older children and adults, is not yet fully developed in babies. This anatomical immaturity explains why reflux is so common early in life and why it usually resolves as the infant grows. Just as some additional information, the angle of His, also known as the esophagogastric angle, is the acute angle created between the cardia at the entrance to the stomach and the esophagus. It helps to prevent reflux of stomach acid into the esophagus. FGID diagnosis relies on the Rome 4 criteria, internationally agreed upon diagnostic guidelines that were last updated in 2016. These criteria help differentiate between normal infant behaviours and conditions requiring medical attention. Using the Rome 4 framework ensures consistency in diagnosis and avoids unnecessary investigations or pharmacological treatments. Now let's discuss lactose intolerance, a condition often overdiagnosed in infancy. Primary lactose intolerance is quite rare in infants because lactase is naturally abundant at birth. Secondary lactose intolerance, however, can occur temporarily following gastrointestinal inflammation, such as after gastroenteritis. Symptoms can include bloating, loose stools, abdominal pain, or gas. Most cases resolve within a month or two, and infants typically tolerate lactose again once the gut lining recovers. It's crucial to differentiate lactose intolerance from cow's milk protein allergy, since the management is completely different. While lactose intolerance only involves gastrointestinal symptoms, cow's milk protein allergy often presents with additional skin and respiratory symptoms such as eczema or wheezing, but not always. Because primary lactose intolerance is rare under 5 years of age, cow's milk protein allergy is often more likely the cause when symptoms persist. Correct diagnosis prevents inappropriate dietary changes and ensures timely referral. FGIDs carry a significant burden not only for infants, but for families as well. Short-term consequences may include feeding difficulties, early discontinuation of breastfeeding, parental stress and fatigue, and reduced family quality of life. Long-term impacts can include behavioural and developmental concerns, and even a higher likelihood of gastrointestinal disorders later in childhood. Clearly, FGIDs are more than just a phase. They meaningfully affect family well-being. There is also a notable economic burden associated with FGIDs. Parents often purchase over-the-counter remedies, many of which are unnecessary or ineffective. There's also a gap between what guidelines recommend, primarily reassurance and nutritional strategies, and what is happening in practice. This leads to overprescribing, increased costs, and unnecessary interventions. In the next section, we'll walk through evidence-based management guidelines for FGIDs, including regurgitation, reflux, colic, constipation, and lactose intolerance. We'll also emphasise when nutritional first-line options are appropriate and when pharmacological approaches are not recommended. When managing regurgitation or mild reflux, we start with simple feeding adjustments. Avoid overfeeding by offering smaller, more frequent feeds. Encourage mothers to continue breastfeeding. For formula-fed infants, thickened formulas may help reduce the frequency of regurgitation. Clinical guidelines from the SPGHAN and the NASPGHN strongly emphasise the importance of parental reassurance and nutritional advice as first-line management. Specialised anti-regurgitation formulas may be useful when regurgitation persists despite the feeding adjustments. These formulas contain thickeners, and the type of thickener does matter. Carob, bean, gum-based formulas maintain their viscosity more effectively than starch-based ones and may reduce regurgitation more reliably. For colic, the most important interventions are reassurance, continuing breastfeeding, and avoiding unnecessary medications. There is limited evidence supporting routine use of specialised formulas, though certain families may benefit from specific dietary approaches. For constipation, continue breastfeeding, ensure correct formula preparation, and educate parents on normal bowel patterns. In some cases, lactulose may be considered, though it can increase gas. For formula-fed infants experiencing colic or constipation, formulas containing prebiotics, beta-palmitate, and reduced lactose may help. Prebiotics promote a microbiome profile similar to breastfed infants, leading to softer stools. Beta-palmitate improves fat absorption and reduces stool hardness. And reduced lactose can help minimise the fermentation-related discomfort. This table compares commonly used formula options for colic and constipation. Products differ in protein structure, prebiotics, beta-palmitate content, and carbohydrate composition. Understanding these differences supports more targeted recommendations for families. Management of suspected lactose intolerance begins with reassurance and continued breastfeeding. Lactose will remain present in breast milk even if the mother reduces her own intake. If lactose intolerance is confirmed, low lactose formulas may help, but soy formulas are not recommended for infants under 6 months of age.
Hello, I'm John Bell. I'm a pharmacist. I've been a pharmacist for more than 50 years now, and I've got a passion for self-care. Pharmacists are very often consulted about functional gastrointestinal disorders in infants, colic, constipation, and reflux or regurgitation. In fact, studies have shown that at least 75% of pharmacists in the community are asked to give advice about these conditions at least once a week. When it comes to recommending a treatment for FGIDs in infants, I think most pharmacists at the moment would be recommending a medication. I think that's what they believe the parents expect, and indeed often that is exactly what the parents expect, and we really know that this is not the best approach. We pharmacists have a responsibility to provide an evidence-based approach to the treatment of FGIDs in infants. Current guidelines for the recommendation of treatment for FGIDs in infants is first of all parental reassurance and then a nutritional approach. An anxious parent means an anxious child, and that just exacerbates the situation for both parents and children. Of course, parental reassurance is so important. It involves making sure the parents, particularly the mum, of course, is looking after herself. That parents understand what the condition is, generally what causes it, and how best we can treat it, and also that these conditions, these functional gastrointestinal disorders, are self-limiting. In 12 to 18 months, they're just a distant memory. Along with parental reassurance, we know the next most important thing is nutritional advice. And if the mum is breastfeeding, it's important to make sure she understands the importance of continuing to breastfeed. For bottle-fed infants, then there may be an appropriate tailor-made specific formula that the parents could consider and we could recommend. And also, of course, there are feeding techniques. For certain conditions, it might mean maybe more regular, less volume type feeds. We pharmacists are very practically minded, so we should think about some practice tips we can give those parents. For regurgitation, for instance, just holding the baby upright during and just after feeding. For colic, comforting the baby, reassuring the baby. Colic's generally a cry for support from the baby. For constipation, sometimes a dietary change, but rubbing the baby's tummy often works. These are the kind of things that can make the baby feel much more comfortable, and of course the parents are more comfortable as well.
Both the ESPGHN and the NASPGHN endorse a nutrition-first approach for managing common FGIDs combined with parental reassurance. This remains the safest and most evidence-based way to support infant comfort and family well-being. In Australia and New Zealand, a wide variety of over-the-counter products are available for infant GI symptoms. However, despite their availability, strong evidence indicates that pharmacological treatments, particularly proton pump inhibitors and prokinetics, are not recommended for uncomplicated reflux, colic, or regurgitation. Unfortunately, prescribing rates remain high, revealing a significant gap between guidelines and real-world practice. Pharmacological therapy is often unnecessary and may even pose risks. PPIs, for example, can alter gastric acidity and potentially impact immune tolerance, with some studies indicating a link with increased allergy development. Despite this, PPIs are still frequently prescribed for crying infants or simple regurgitation, which highlights the need for ongoing clinical education. Let's shift now to the role of the microbiome. The first 1,000 days from conception to age 2 represent a critical window for immune, metabolic, and gastrointestinal development. Nutrition plays a major role, and breast milk remains the gold standard during this period. During this early developmental window, the infant microbiome and immune system undergo rapid foundational changes. Optimal nutrition supports these changes, reducing the risks of allergies, infections, and GI disturbances. Breast milk is uniquely complex. It contains lactose, lipids, proteins, cells, and immune factors. But one of the most important components are the human milk oligosaccharides, otherwise known as HMOs. HMOs play a major role in shaping the infant gut microbiome and supporting immune maturation. To help parents understand the microbiome, you can use this simple analogy. Think of the gut as a garden. Good bacteria are the flowers, while harmful microbes are the weeds. Prebiotics act like the fertilizer, helping beneficial bacteria thrive. Probiotics are like planting new flowers. A balanced gut supports healthy digestion and immunity. Human milk oligosaccharides are the third most abundant solid component of breast milk. More than 200 structures have been identified, each offering unique benefits, from gut development to immune support and improved stool characteristics. In 2002, the first prebiotic blend was introduced into infant formula, combining short-chain GOS and long-chain FOS in a 9:1 ratio. This blend was designed to mimic some of the functional benefits of HMOs and is now supported by more than 40 clinical studies. It has been shown to improve digestive health and promote softer, more frequent stools. Although synthetic HMOs, known as HIMOs, are now added to some formulas, it remains impossible to replicate the full diversity and concentration of natural HMOs found in breast milk. The potential is promising, but ongoing research is still required. This table illustrates the differences in concentration, diversity, and structural complexity between natural HMOs, the GOS-FOS blends, and commercial HIMO offerings. While each option offers benefits, none fully replicates the complexity of human milk. To summarise today's discussion, FGIDs are common but usually benign. Reassurance and nutrition-first strategies are the foundation of management. Breastfeeding should continue wherever possible. When formula adjustments are needed, they should be evidence-based and targeted. And finally, unnecessary medications should be avoided. Our goal is to help families move from the vicious cycle of crying infants and anxious parents to a virtuous cycle, where infants are comfortable, parents are reassured, and unnecessary medical interventions are minimised. This is best achieved by pairing parental reassurance with nutritional guidance. First-line management always begins with reassurance. Explain that regurgitation and colic are common and usually temporary. Reinforce correct feeding techniques and safe, soothing strategies, avoiding recommending medications for colic or mild reflux as they rarely offer benefit and may carry risks. Breast milk remains a gold standard and should be supported wherever possible. For formula-fed infants who continue to experience discomfort despite appropriate feeding advice, specific nutritional solutions such as thickened formulas or those tailored for colic or constipation may be considered. For regurgitation, thickened formulas are often effective. For colic, probiotics such as Lactobacillus reuteri may help in breastfed infants, while formula-fed infants may benefit from partially hydrolyzed or symbiotic formulas. For constipation, consider formulas with prebiotics, beta-palmitate, or slightly higher magnesium content. When FGIDs arise, always begin with a nutrition-first mindset. This approach supports the infant's comfort, improves quality of life, and reduces unnecessary healthcare costs. Clear, consistent reassurance from healthcare professionals makes a tremendous difference for families. Finally, remember that ongoing support is essential. Nutricia Careline team, including midwives, dietitians, and nutritionists, is available to assist both healthcare professionals and parents. feel free to encourage families to reach out for guidance, reassurance and practical feeding advice. Thank you for your time today.